Thank you very much. If you don't mind, I'm a little podium averse. I think I'll just come to the side. Well, I'm thrilled to talk with you, and for the qualitative researchers in the room, I think we can be assured that we have reached saturation on our themes, and so I'm going to just affirm several of them, but I'm going to talk to you a little bit from both from my academic experience, my state government experience, and my boots on the ground local public health experience, and sort of give you some lessons that we learned in Ingham County, which happens to be a community that was afforded lots of opportunities to get it wrong and then to get it right. And so we'll just share some of those with you. Public health leadership. And I've been thinking a lot about public health leadership since accepting this new position 8 weeks ago. And I love this quote from an article by Cohen Jackson that says, "Public health problems pose special challenges. They're generally enormous in scale. They stem from numerous and highly complex causes. They play out in the public. They impact a vast array of stakeholders, and they require an unusually long-term solution." This is the context in which we are endeavoring to partner and to improve the health. And, my bosses don't like stakeholders being upset, and they don't like the media, and so the challenge is that it is about the mission that keeps us at the table, and it's almost our being excited, for lack of a better word, about the controversy that causes us, as Jackson and Quo say in another part of their publication, to leave the safety of the sidelines and to wade into that controversy. And so one of the things that we've been pushing ourselves to think about is, what do we mean? What do the words mean? Because we'd have this complete conversation, and as you've heard before, at the end of the conversation, we realized neither had any idea what the other person was talking about. Yet we were all speaking words in the English language. So collaboration is not community engagement, is not community organizing, is not collective impact. And as a community in Ingham County, we've been trying to get comfortable with what we mean by any of those terms. And I'm going to share one historical example from our Community Voices experiences, and then a couple of others. But a couple of the things that we've been really emphasizing is, again, this long-term commitment, which is a part of the definition of collective impact. And a couple of characteristics of collective impact. One, it has to be about a shared measurement system, has to be about mutually reinforced activities, and it has to be about ongoing communication. And those highlighted words for us really underscored a couple of things. You're in it for the long haul, till death do we part, and hopefully not till premature death do we part, right? And the other is that this is about sharing power. To talk about sharing things and mutuality, it's not we're the big dogs, I'm the statutorily bound individual that protects your health. It is about how are we going to use the power that I get from this position to position you as our partners. And so kind of pushing through that, and this was a model that we came across that really just highlighted that for us in conversation. So collaboration is about convening around programs. Public health, we describe ourselves as the neutral conveners. What a joke. We have a dog in the fight. We are not neutral. We will pull you together under a pretense, but I think we have to be honest about that. But collective impact was more about working together to move outcomes. Collaboration, we're trying to prove some things, and collective impact, we're trying to improve some things. Collaboration is, okay, who's the collaboration coordinator? This is one more thing we have to do, whereas in collective impact, it is how we do what we do. And then lastly, that it's not about advocating for ideas. It really is about advocating for what works. And because of that, even though we come with a dog in the fight, we sometimes have to shift and say, we are really concerned about obesity, childhood obesity. It's important to us. And the community is saying, but if our kids don't live to be 10, it doesn't matter if they're fat while they're under 10. they were concerned about violence and safety. So really being able to use concepts of collaborative leadership, and this is from an RWJ project, Turning Point, that defined collaborative leadership, making 2 points I think most critically important, and that is that all the people affected by the decision are part of the process, and that we think very differently about this notion of power. Who has it? Why do we have it? What do we do with it? So as we began our conversations with community organizing partners, and this through a joint project with NACHO, the National Association of Cities and County Health Officials. I happened to be honored to be chairing their Health Equity Social Justice Committee at the time that this initiative was getting going, and got to be a part of a lot of those conversations. And we really began thinking about what is the dynamic and the relationship of power. And so in Ingham County, starting back in the early 90s, when we were a Community Voices funded site by the Kellogg Foundation, we continued to play around with sort of 3 spheres of influence, that being leadership, being the vehicle with which we get an endorsement or a mandate, a requirement, and even adults don't like being mandated to do things. We have a health equity social justice coordinator, and we went around and around the bend on whether our workshop should be mandatory or not. And it's like, well, we really want people to want to do it and to not have to do it. And so I abrogated power because I wanted to make it mandatory. Our health equity coordinator said, no, let's just get a critical mass. Let's get the early adopters. And then after a while, we got to the point with the stragglers where we didn't make it mandatory. We just sort of voluntold them that they have to come to the training. So what is that leadership requirement? And then what is the community's contribution to this? How do we engage with them? How do we allow the advocacy to come from the community members? And I used to say, how do we let the community lead up? But it really isn't even hierarchical in that regard. It is really about leading, and that whole idea of what a leader is and what a leader does has been expanded in our thinking based upon our communications and relationships with community organizers. And lastly, the workforce. Are we empowering staff, which in a bureaucracy can be very dampened down, but are we allowing them to challenge the status quo that we've put in place institutionally? And so we all come together, and collective impact is really about, 3 strands not being as easily broken as 1 strand, and seeing ourselves as part of the same, with this tension that's forcing us to be pushed together. Because just as Dr. Simon was suggesting, whenever I'm in a meeting, I always have this out-of-body experience, because they say, well, you're the health department, or you're leadership, or you're academic. Well, I live on the west side of Lansing. I'm like a community person too. So how do we give place to that? And how can we allow people to to bring their whole self to the table? To not necessarily compartmentalize, but to recognize I'm a person of faith, I go to this church, I'm also on this board, I also have this knowledge of research because I had this fun. Bring your whole self to the table, because the workforce is the seeding ground for leaders, institutional leaders. The community is the seeding ground for the workforce, and we are all multicultural. So how do we accept that and give space for that? So back in the 90s, when we were a Community Voices funded agency, the Ingham County Health Department began to perfect, and I do say perfect, the skill of facilitated dialogue, which is a methodology, it is a process. And we saw ourselves as the health department in community. And the challenge began, how do we get community groups, community organizations, and neighborhoods to see our resources as their assets? We're only here because of you. And how do we also get our own organization, how do we get the health department to view the community's assets as our best resources? That mutuality, that web of mutuality that Martin Luther King referenced. And so we began to do dialogues across sort of geographically identified dialogues. And out of the push and the leading of the community, established many structures and institutions and organizations that began to help us do the work. We now have a Northside Neighborhood Network Center, we have a Southside Network Center, we have the African American Health Institute, we have the Latino Health Alliance, we have all of these things because the community drove us to use our power to establish those entities. And it has served our community extremely well. So this has been a long process for us. We don't do health equity really well because we started doing it when people started talking about health equity. We've got some history and some relationship. And then we got the support of our mayor, who at the time started an initiative on race and diversity. And so it's been a building of relationships. The power of we is probably the best representation of that model of relationships in our county. At the time, our governor required the human services agencies that were getting a particular funding revenue to convene. The health department director, the community health director, the human services director, the office on aging director, the four of them had to meet regularly to make sure there was no redundancy. And for whatever reason, and I would argue it was because of some of that dialogue and learning we got individually as well as institutionally in the past, those four leaders said, well, why should we just be the only ones at the table? Why don't we open this up to the community? Let's all talk about this together. And so over time, what was referred to as the Human Services Collaborative is now referred to as the Power of We Consortium. And it really is a network of networks. And each coalition is out addressing whatever their issue is, the Infant Mortality Network, the Refugee Services. We are a refugee resettlement community. And so whatever that coalition was, we started figuring out what are the networks out there. And hey, why don't we all come together once a month and just share? Just open lines of communication. We now are just in the process of closing sort of an agenda setting tone, that sort of collective impact model, where we're looking at equity as the undergirding purpose for all of our coalitions. And so the most current activity that we've been doing in Ingham County has really been leading a statewide, regional push to get public health professionals to partner with community organizers. And the amazing thing, because we thought as public health professionals that, oh yes, we do community organizing. And our community organizer colleagues would say, well, no, not quite. You guys do community engagement. Right, that's what we said. We organize the community. Well, and so around and around we would go. And finally, public health colleagues started figuring out, wait a minute, community organizing is like a thing. It's like a field. They have a science. They have a methodology. They have a history. They have credentials in a sense. I mean, if you listen intently to the community organizers that spoke before us today, these are smart folk. They're using words like the dominant narrative, and they're quoting people like John Powell, and they're deconstructing race, and all of these amazing thought-provoking phenomena, for lack of a better word. And we began to say in public health, okay, well, what are we bringing to the table? We understand that community organizers have this way to win concrete improvements for people's lives. They do these very effective health impact assessments in a very deep way that changes the structure of people's lives. They go talk to powerful people. What do we need to do to partner more closely to help in that regard? And so our attention in this initiative called Building Bridges, which is now really the twin of the Power to Thrive movement, which our colleagues at PICO and Isaiah helped us to establish and bring together, has been about how do we mobilize those community partnerships to help solve health problems. And as you've heard today, health, it's almost all about health. There just happens to be that umbrella, that education is tied to health, that employment is tied to health, safety is tied to health. I tease my colleagues in Ingham County, and I say, yes, you're all public health workers. Thank you for your help. How do we begin to see that? How do we begin to do what we're supposed to be doing in the 10 essentials of public health around educating, advocating, empowering? And how do we shift our lens so that we see the community not as clients, which is what we do in public health, but as partners. So we in Michigan, with our Power to Thrive, have been doing what I would say, describe as building a shared culture for change and for action. We have local health departments, about 5 around our state, that have come, and in many cases we have very strong community organizing entities and not as strong public health departments, and in other areas we have very strong, very progressive, very robust public health departments and not as strong community organizing. But I tell you, in my community, it has been so gratifying. We were a community that had a pretty progressive local health department, a pretty quiet and marginalized community organizing entity. That community organizing entity has really gotten such a jump start even from this initiative, that the visibility, even the leadership of that group began thinking differently about who they employ. And so we now have, are both very strong partners, local health departments thinking about, again, community health, what's the local context, and community organizers bringing that very applied lens to social determinants of health, doing what I learned is described as cutting issues. And are we going to be able to find a statewide issue to cut, or are we going to do regional issues, and how are we then both going to bring in our own expertise, that public health expertise, that community organizing expertise, and really establish a model of synergy that lets us have candid and authentic conversations and discussions with each other that are moving us toward action. So because we do facilitated dialogue, again, as a methodology, we've had to push a lot to really distinguish not conversation, not debate, not discussion, but really dialogue. So if you think about these contrasts, I'm going to show you 3 quick slides to contrast those things. That a debate is really about kind of highlighting competing factions, coming up with the best solution, that whole sort of compromise model, which we don't happen to like. We're sort of socialized in this world to an either or, and compromise means you're not really getting what you want, I'm not really getting what I want, but we're going to pretend like we're happy and just go forward. That in debate, we're trying to convince you and persuade you. And we just got to a place where, no, this is about dialogue. We're trying to highlight what's our common purpose, not our competing purpose. We can talk all day about what we don't agree on, but how can we get to the place of agreement? That there are lots of solutions. There's not just one solution. There are many, and we want to emphasize not on persuading you, but on listening to you. And I think it was one of my community organizing colleagues that said, think about the word listen. What is the only other word that you can spell using all those letters that is a separate and distinct word? Listen converts very naturally to silent. So we've been sort of studying to be silent and to hear and listen to what our partners were saying to us. So training, when we were doing our workshops, our health equity, social justice workshops, we were very clear that these are not trainings. We're not going to be sort of unilaterally pouring a bunch of information into you. A training is embracing what is known. It's teaching new solutions. We don't know what's known around how to really advance health equity in this nation. We don't know for sure how you get there. We know what that destination is, but we're going to embrace the journey as our colleague said, and know that the roads are going to get us there. Not teaching new solutions, but discovering new solutions. When we do our facilitator training, we're always trying to push folk out the nest. Okay, you ready to do a workshop? I'm not ready to do a workshop. I feel like if people ask questions, I'm not going to have any answers. I don't have the right answers yet. And we say, then you are ready to facilitate. Because facilitating is not about having the answers, it's about having the questions. And amazingly, seeing then the answers evolve very organically from the experiences of the people in the room. And lastly, we just wanted to get people to understand that we're doing more than having a conversation. Now, we have lots of conversations before the dialogue. When we were doing our partnership with our hospital systems, our health systems around our community health assessment, 6 hospital systems, 3 local health departments, I did lots of conversations before the meeting. Hey, just checking in. How are you doing? Any concerns you have about the agenda? You know, just trying to build that social capital with people. But it's not what we do when we're facilitating change for health equity through dialogue. So conversation, casual, unidirected. Dialogue, on the other hand, is very vigorous. It's okay to disagree in dialogue. And again, we're not debating. We're just having a passion, mission, controversy-driven discourse. Conversation, we want to kind of marginalize the differences. Well, you know, actually, we're kind of saying the same thing. No, we're welcoming difference so that we can wade through that. And again, not about consensus, but about a collective approach that does a both and. And so one of the things that we sort of philosophically have been trying to do, this is a quote I came across by Antoine de Saint-Exupéry, and the Renée Canady translation is, get out of the way, institutions, and trust the solutions and the answers to come up. If you want to build a ship, don't drum up people to collect wood and don't assign them tasks and work. That's what we do as bureaucrats. You take care of this. This is what we do in our emergency preparedness response. Okay, let's see what's happening in operations. Let's see what's happening on the supply chain. What are we doing? That's what we're trained to do. But we don't want to do it. We want to teach people to long for the endless immensity of the sea. And that endless immensity may look different in your community than in my community, but it's all about being healthy and being whole in all of the many aspects that we define health and wellness. And so we're excited. I'm honored now to be a partner and sometimes even a funder of this work in my new role as the leader of the Michigan Public Health Institute, continuing to be a part of that public health continuum, but always recognizing that the buck doesn't stop with us. The buck goes around and around and around. So thank you.